Hi, everyone. I'm told I'm supposed to start right at 9 because we have M&Ms after. So I'll get started, and if you're just coming in, you can take your seats at your leisure. So I'm Sebastian. That has not changed since yesterday. And I'm going to be discussing how we can talk to our patients in ways that helps them understand, specifically when we're giving them our discharge instructions or when we're discussing medical risk with our patients. So I'm going to start with a quick story. About a year ago, unfortunately, my grandfather started falling more often. And after one of his falls, he had a lot of pain in his shoulder. So he went to the Montfort Emerge. They spent most of the day there and then came home in the early evening. And I went to go see them after supper. Now, just to give some background, my grandfather's a pretty bright guy. He has an MBA. At the time, he was still reading the newspaper every day. And when you would speak to him, there was no evidence of cognitive decline in kind of day-to-day conversation. However, when he came home from the emergency department, these are the things that he was telling me. So first, his arm was not broken, it was just a fracture, and it took some time to convince him that they were the same. And I think this is like a common, certainly in my family, this seems to be a common misunderstanding. Secondly, before the fall, he'd been doing some general physio exercises for strength and conditioning, including some overhead tricep extensions. Now, I think probably the emergency doctor told him he could take his sling off to do range of motion exercises, but he got the message that this sling was completely optional and he should continue doing his physio with small weights and overhead and all that, which I'm sure was not the emergency doctor's idea. And finally, he really just did not understand the plan. He wasn't sure if someone was supposed to call him or he was supposed to call someone. He thought that maybe a surgeon might be coming to his house to see him, but he also thought that seemed extremely unlikely. And in fact, it was the CCAC representative who was supposed to call the house to talk about fall prevention. So kind of overall, he just didn't really know what was going on. And I don't mean to say that it's the emergency doctor's fault for doing a bad job with their discharge instructions. And my grandfather, I think, was better able to understand the instructions than many of our older patients. I just give this example to highlight how even for relatively simple diagnoses, patients sometimes will really not understand the plan that we set out for them. So in terms of objectives, this talk is maybe kind of like a fluffier topic, so I wanted it to at least be immediately useful for you guys. So I'm going to talk about 3 strategies to improve our discharge instructions, and I hope that at least one of them will be something that you can use on your next shift. And then we're going to discuss conveying risk to our patients, and by the end of the talk, you should know what a natural frequency is and how we can use it to help our patients understand risk. So I'm going to start with a quick poll. I'd like you to raise your hand if you routinely give some form of discharge instructions to your patient. Yeah, so it's everyone. Okay, now I'd like you to raise your hand if, in general, you think those discharge instructions are very poorly understood with many dangerous errors. So actually a surprising number of hands. Okay, and then just poorly understood. So that's the majority. Well understood with just a few errors. And then I guess that no one's going to say perfectly understood. So several studies have looked at patient understanding of our discharge instructions. And in general, about 2 out of every 3 patients will have fundamentally poor understanding in at least one of these 3 domains. So what their diagnosis was, what the treatment plan should be, or precautions and reasons to come back to the emergency department. I'll just briefly say that these studies were mostly retrospective, and in general, the quality of the studies were not high. However, all their results agree with each other, and they also agree with a set of studies looking at the same thing for patients discharged from hospital. So together, this would suggest that this is a real phenomenon. Last year, Hassan did a study in our department for his resident research project and found basically the same thing. So a majority of patients had poor or no understanding in at least one of these 3 domains. And also, a significant proportion of our patients received what he termed incomplete discharge instructions, which meant that when someone else was listening to them, at least one of these 3 main topics was not mentioned at all in the discharge instructions. So clearly, we also have some room to improve. And this leaves us in a kind of a tricky situation where many of our patients are leaving the department not really knowing what's going on and feeling a little bit lost. As of yet, there's been no studies assessing whether poor understanding of ED discharge instructions directly leads to poor outcomes, but this relationship has been demonstrated for patients being discharged after an inpatient stay, where there's increased rates of medication errors and increased readmission rates for patients who demonstrated poor understanding of their discharge instructions. It seems logical that these results would also apply to our setting, and so I would submit to you that we should make efforts to improve our own discharge instructions. So before we discuss possible solutions, I'd like to do a quick exercise. I'd like you to pair up with the person beside you, and one of you is going to give the other one the discharge instructions they would normally give to this patient. So you not the kids, but the middle-aged man with chest pain that you're going to refer to cardiology for risk stratification. So I'll give you about 2 minutes, and then we'll move on. Okay, I'm going to cut you guys off. So I'd like you to keep that conversation in mind as we go through the next couple slides, okay? So we're going to discuss 3 relatively straightforward ways to improve our patients' understanding of our discharge instructions. The first is to keep your message simple, editing out any unnecessary language or unnecessary content. The second is to use good quality, patient-specific written handouts. And the third is to directly verify that the patient has understood your discharge instructions. So let's first start with simplifying your message. This can again be broken down into 3 parts. First, wherever possible, we should be using simple language, and specifically we should avoid any medical terms. This is probably the point that gets the most attention and is taught relatively early in medical school, but it's still a pretty easy trap to fall into. Surveys of emergency department patients have shown that they're not familiar, for instance, with most of the anatomic terms that their doctors use. Using these terms can overload the patient's working memory and makes it very difficult for them to then follow the rest of the discussion. The second point is that it's important to think about the content of what you're saying and specifically try and edit out any unnecessary content. So think to the discharge instructions you just gave each other, and if you're the one receiving the instructions, I'd like you to try and think of how many discrete points the other person made. Raise your hand if it was less than 3 points. So no one. Raise your hand if it was more than 3, more than 5, more than 7, more than 10. No. So the average seemed to be between 5 and 7. Consider that in a typical hour-long lecture, most people would suggest that you should make a maximum of 3 to 5 points. Or alternatively, if you were going to do some formal teaching with a learner for 2 minutes, how many new ideas would you try and convey in that time? Probably not more than 1 or 2. So when we talk to our patients, it's really important to focus on what we really want them to know and edit out any extraneous information that may be distracting to them. And then the third strategy is just planning your message in advance. In fact, several studies have shown that using standardized, scripted discharge instruction leads to better patient understanding and better recall of those instructions later. I suspect that most staff and probably many residents have kind of informal scripted discharge instructions that they use for common presentations. I think this is a great practice. I would just suggest that you take the time occasionally to go through them in your head and monitor to make sure that there's no confusing language or you're not having too many details. And if you do find that maybe your scripted version is a little bit complicated, you might want to rework it so that it's a little bit simpler to follow. So I thought I'd give a math example to highlight the benefit of having a planned message. I chose math for two reasons. One, I just like it, and so does Dr. G, my supervisor. And then the other one, though, is most of you don't particularly like math, which more closely mirrors our patients' experience because they don't generally have a lot of medical knowledge. So here we have, I've presented a fact that at least theoretically should be understood by most high school students. And I'd like to ask who sees like an obvious proof to this theorem. So I see no hands. I'd like to ask now, who immediately remembers what a rational number is? So again, no one. So just to refresh your memory, a rational number is just a number that can be written as a fraction, as opposed to an irrational number which cannot be written as a fraction. An example would be pi. So this is just the first proof that I came up with when I thought of the problem. So if you have any two fractions, you can make this function that maps them to the interval 0, 1. This function, I think you'll all agree, is clearly continuous and an isomorphism. And so it falls just to show that the interval 0, 1 contains infinitely many fractions, which is a trivial exercise. Now, I'm being honest, I did not try and make this confusing on purpose. It's just kind of what I thought at first. And it's what... But also most undergrad math students would find this pretty easy to follow, and many would also think of it first, because it uses a lot of undergraduate math ideas. You had a question?
But 0 isn't a rational number.
It technically is, because 0 on anything is 0. So 0 on 2 is 0 still 0. Yeah, it is. But it was a good try, Nick. So if instead of saying the first thing that I think of, I take some time to think of my audience and plan my message using ideas that they're likely to be familiar with already, I might come up with something more like the following. So first, you can just get rid of the word rational and substitute fraction. And now at least everyone kind of understands the problem that we're trying to solve. So we have any two fractions. We're trying to show that there's an infinite number of fractions between them. And then I can simplify the proof so that it uses only concepts that you're all going to be familiar with already. In particular, if you have any two fractions, you can always take their average. We'll call that average m. And m is clearly a fraction because I've written it there as a fraction. Also, if a and b are different from each other, then m must be different from a or b. So in this way, I've found that no matter what a and b are, I can always find at least one fraction between them. To make this even easier, you could show it pictorially. So if this is a number line and a and b are two fractions, you can always find the midpoint, which is the same as the average. And this midpoint, again, you can write as a fraction, and it's clearly different than a and b. Since n is a fraction, you can apply the same thing now to m0 and a, and you can find a new midpoint between m0 and a, call it m1. And if we zoom in a little bit, it looks very similar to our previous slide. And we can again find a new midpoint between a and m2. And this can obviously carry on indefinitely. So in this way, we find infinitely many fractions between the two original fractions, all of which are different from each other. So the notion I was trying to explain was the same the both times. The only difference was that the second time I put some thought and planning into my message, and I would suggest that most of you probably found it a little bit easier to understand. The same thing would apply to our patients, and how confused you felt when I did the first explanation is probably how confused many of our patients feel often when we're giving an overly technical medical explanation. So now I'm going to talk a little bit about written discharge instructions. So a Cochrane review and multiple ED-based studies since then have shown that providing diagnosis-specific written discharge instructions improves patient understanding and retention of important details. However, the Cochrane review did also caution that there was a variable effect size between studies, and this is likely because the quality of the written discharge instructions is variable between studies. Luckily, there's a lot of literature from several academic fields, not just within medicine, that guide us in how to create useful written instructions. Unfortunately, it's kind of rare that these guidelines are well followed. I've pulled out a couple of key points from the literature. So the first is addressing the reading level of the document. Studies show that the median reading level of ED patients in the US ranges from grade 3 to grade 6. And more recent studies show that even if you exclude all the people who are illiterate, the average reading level is still around grade 6 or 7, which I found surprising because it's not how I think of our patients except for when I'm rotating through CHEO. The next point is probably the hardest to achieve, and it mirrors the point we were talking about earlier with our verbal discharge instructions, in that it's important to focus only on the key content and edit out any unnecessary information. People can only take in a few new ideas at any one time, and if a patient doesn't understand the discharge instructions the first time they read through them, it's very unlikely that they're going to try and read them a second time. People are also easily overwhelmed by too much text, and they prefer as much white space on a page as possible. Unfortunately, when people are creating these documents, and especially when medical professionals are creating these documents, we have a tendency to want to include as much information and as many details as possible. This has the unwanted consequence of making the document essentially useless. And then finally, we know from multiple fields that using multimedia texts with images are better understood than plain text alone, provided those images are relevant and add something to the document. Now, most of us, or most of you, will not be ever directly involved with creating written discharge instructions, but you can use these same three principles to evaluate other written discharge instructions. And especially, I know many people pull their discharge instructions off the internet. So if you have several options to choose from, you can use these to help you decide which option will be best understood and most useful to your patient. For example, this is an objectively suboptimal patient handout. The text is illegibly small. The only thing that you can read comfortably is the corporate sponsor. Secondly, it's crammed with all kinds of information from exercises, stretches. There's a section on how to avoid getting a dowager's hump. But the part that talks about what to expect with your acute back pain and how to manage your acute back pain doesn't arrive until the back of this document, which is just as crowded as the front. This might be useful to the most ardent of readers, but the majority of people, it will just end up in the trash before they leave the department. And Dr. G was telling me he trained in the States, and they have very comprehensive discharge instructions there, like leaflets. And after the shift, they would go outside, and they were just all over the ground outside the emergency department. So this, in contrast, is a much simpler form. It's well organized. There's a clear emphasis on using plain language. And this is a form that patients are much more likely to read, to keep, understand, and remember. So what about our own written discharge instructions? We have our own ones that are available in urgent care. And I'd like to kind of poll the audience on which ones do you use. So kind of shout out one that you routinely use. Head injury. Abscess. Laceration. Gastro. Cast care. There's also a suture care one. Any other ones that you use a lot? Anyone that does it at CHEO? Yeah, there's a lot about CHEO that they use pretty routinely, actually. So I asked a couple people, and it seems that most people have kind of like 3 or 4 that they use, but not more than that. I went through all of our discharge written handouts, and the first thing that struck me is we really have a lot. So there's at least 25 sets of discharge instructions. There's several about procedures like lumbar puncture or cast care, how to care for your new Foley catheter, how to care for your sutures. And there's also several for discharge diagnoses like UTI, renal colic, hypoglycemia, bleeding in pregnancy, cellulitis. It's quite a long list. In general, the reading level of the documents is somewhere between grade 7 and 9, which is about the same as most newspapers. They may be a little bit tricky for some of our patients in some areas, but a majority of our patients will still understand most of the documents. And in general, they're pretty good. Unfortunately, that first back pain handout I showed you is one of ours, but it's by far an outlier. In particular, it's the only one that was not created in-house. And all the ones that were created in-house are well organized. It's clear that there's been an effort to use simple language, and they're pretty easy to understand. Certainly, I think they're good enough that we should probably be using more of them, like a wider range of them. And at least personally, I've made an effort now to use them more routinely. I'll just mention briefly an idea that doesn't come out of the literature, but I picked up from a couple of our staff here. So for some patients have more complicated cases, maybe you gave them several diagnoses, started several new medications, or the follow-up plan is more complicated than usual. In those cases, you can just quickly write out like a custom discharge plan for that patient to help them remember what the plan is. So this is one that I wrote out recently for a guy who came in with a history of renal colic, coming in with flank pain that seemed likely to be renal colic again, and we were going to get a next-day ultrasound for him. But he also had a new left leg cellulitis that we were going to treat. So this just kind of lists his diagnoses, give a quick description of the two antibiotics, the two medications I'm starting, and then gives kind of a bullet point plan to help them remember what it is that they should be doing when they get home. The final important step in providing quality discharge instructions is to assess whether or not the patient has understood them. So consider the last time you were teaching a learner something. I would guess that you probably made some effort to see whether or not they understood what you were saying. Now think back to the discharge instructions you gave each other at the beginning of the talk, and I'd like you to raise your hand if they explicitly checked for patient understanding in them. Yeah, so there's no hands. And in fact, multiple studies show that this is something that physicians, not just in the emergency department, but everywhere, do quite poorly. Assessing for comprehension has several benefits. First, of all the strategies to improve patient understanding of discharge instructions, this is probably the simplest and easiest to implement. Secondly, it allows for targeted reinforcement or correction of points that the patients either don't understand or remember incorrectly. And third, it cues the patient that what you're talking about is important. In fact, you think it's so important that you're taking the time to check that they understood it. Unfortunately, just asking the patient if they understand the plan does not work very well. Multiple studies have shown that there's almost zero correlation between the patient thinking they understand the plan and their actual understanding. And what was surprising to me is the more postgraduate study degrees you have, so the more masters and PhDs and postdocs you have, the more likely you are to truly believe that you understand what's going on when you have no clue what's going on. So instead of asking them if they understand, we should ask them to repeat the plan back to us. There have been no trials looking at this in the emergency department, but several studies in primary care and surgical clinics have shown that this technique results in better patient understanding and better recall of important information. Personally, I, at least at first, found that this would seem a little patronizing to the patients, but since implementing it in my own practice, I have not found that patients take it that way. In fact, it's often the case that the patients become more engaged in the conversation at this point, and I'm also routinely quite surprised by what the patients tell me that they think I've just told them. So to sum up, I don't know if you could call them easy necessarily, but our three main strategies for improving patient understanding would be first to have a simple, well thought out message that's possibly planned in advance for common presentations. Second, think about using more discharge instructions, and if you have kind of a slow shift, you could take a look at the ones that we have already in-house to use. And finally, you can verify that the patient understands the discharge instructions by having them repeat them back to you. So I'll get you to pair up in the partners you were in before and switch roles. So the other one is going to give the discharge instructions for the same patient, trying to keep in mind those three main points. I'll give you 2 minutes again. Okay, I'm going to cut you off again. And I'm going to ask if there's any... I'll ask if there's any questions about the section on discharge instructions. No questions. Okay, so I'll ask you guys some questions. For the last exercise you just did, was there one strategy that seemed harder or easier than the other strategies? Nick?
I found it really difficult to distill the information we need to give in terms of diagnosis, treatment, and return precautions into 1 or 2 points.
Yeah.
You know, the reality is it is a fair amount of information to give. So how do you get that really effective?
Yeah, so the point was that we have a lot of information to give, that a lot of it is important, and how do we distill that into only a couple points? I would agree that, I mean, there's 3 broad categories there, so you would probably need at least 3 points, but so maybe the number of points, it's important to focus on each piece of information you're giving, like, is this part necessary? Am I explaining about coronary anatomy? That's not necessary. But am I explaining, like, you need to call your family doctor? That part is necessary. So as you go through what you're saying, or better yet, thinking about it in advance, it's important to think, like, each part, is this something that's going to help or take away from my message? Which is, I think most people would agree, like, pretty hard to do in the middle of a conversation. Any other comments?
barraging with it, then it doesn't work as well as if you've gone through the whole process all the way along. And the first time you see them, you say, I don't think you've had a heart attack, but I think we're going to do tests. Or you pulled up on your iPad the x-ray and said, see, it's broken right here. And so now we're going to do the next thing. So I think some of those things that we can do in the process actually help prime your patient. And then we say, okay, we're going to do these tests. And then at the end of this, I'll go, so just as I expected, you didn't have a heart attack, but blah, blah, blah. Now we're going to go and do some more testing outside the hospital. So I think trying to think about, we often walk in and say, do the whole history of physical, and then go, okay, so now we're going to do some tests and I'll get back to you. Well, I think that you can do a lot of things that will help the discharge instructions if you talk to them ahead of time.
Yeah, I think that's an excellent point. So for the viewers at home, Dr. Duchesne was saying that we can kind of prime our patients rather than giving them all the discharge instructions at the end. If you kind of know what the plan is going to be early on in the encounter, you can kind of tell them that I don't think this is a heart attack, we're going to do some tests to rule it out. And then at the end, when you're telling them their diagnosis and the plan, they've already been kind of primed for that. One thing I would add to that, kind of along that vein, is if you pick up a chart and you know it's going to be relatively straightforward and there's a handout for that chart, you can bring it into the room with you. And then if the patient's going to be sitting around for an hour, they can have that handout and read it while they're in the department. And then you can, at the end, be like, did you have any questions about the handout? So that they've already, 1, not wasted their time just sitting around, and 2, been thinking about what the plan's going to be.
In London, we did a study to see if there was any benefit to giving patients a handout that very simply explained what we did to them. And it was more, go see your family doctor and give them this, because when you ask them, well, what happened in the merge, they would say, well, they didn't do anything. But really, like, we did an ECG, a chest X-ray, blood work to make sure you didn't have a heart attack. So the family doctor gets this patient with nothing, and they're like, well, I don't know what happened. Because frequently the EMRs aren't synced between the hospital and the family practice. So the sheets that are on the charts of what the family doctor gets from us, I think, is a great avenue to sort of add on to the discharge instructions. You're giving this to the patient, but you're also giving discharge instructions in a sense to the family doctor, saying this is what we did, so that they know what happened to continue their care a week later.
Mm-hmm. Sean, do you have a comment about that?
You saw me raising.
I did.
So we know from a local survey that family docs get very little from patients after they visit the ER. So that's the tough part, is that although we can give patients a lot of information to bring back with the family doctor, we're never really
Yeah. So there was just a couple of comments about even if the patient understands what the diagnosis was, they usually will go and tell the family doctor that basically nothing was done, or they won't know what tests were done. And so the onus is on us if we want the family doctor to know what we've already tested for and we want what we want them to test for next. We have to directly communicate that to the family doctors with the little sheet at the top of the ROT. Okay, I'm going to move on. So we're going to switch gears and talk a little bit about risk. Not so much about world domination, but how to accurately convey risk to our patients. So reading about how people perceive and interpret risk is really very interesting. If you guys have time when you want to do some non-medical reading, I would suggest it. It's a neat topic. I'm going to try and stay relatively focused on more practical aspects of how we can convey risk to our patients in a way that helps them understand and helps them make more confident medical decisions. So the three take-home points in this section are, first, that risk is poorly understood by patients and also, if we're honest, poorly understood by many physicians. Secondly, we're going to talk about what natural frequencies are and how we can use them to help convey risk. And finally, we'll talk about the benefit of using pictograms in helping our patients understand risk. So if you think about risk perception as a human trait, it must be subject to evolutionary forces. This process has left us with a system which is very good at promoting our short-term survival, but it's certainly not infallible. In particular, we're hardwired to react to immediate, concrete threats. So much so that even potentially dangerous situations can evoke a very strong stress response. We're particularly attuned to risk that comes from other people, and I'm sure that everyone can think of a situation where you are walking down a street and there's like a shady-looking character, it's kind of dark, and you feel very unsafe, and there's a very strong physical reaction, even though rationally you know that probably there's no threat from this individual. I'd like you to think about the kind of physical response you get from a situation like that, and then consider global warming. So we've probably already seen a 1-degree rise in global temperatures since the pre-industrial age. The scientific community would agree that a maximum of 2 degrees is the maximum acceptable rise that we could see, or that we should allow. And even that 2-degree rise would be associated with mass extinction events, drought, famine, and the creation of hundreds of millions of climate refugees. The climate models don't have a lot of predictions for what would happen if the temperatures rise by more than 2 degrees, because it seems that the climate will become very unstable at that point. But the predictions we do have tend to be apocalyptically bad. Now, world leaders are currently meeting in Paris to try and tackle this issue. And among the major financial powers, Great Britain has the most aggressive anti-climate change plan, although they have really no idea of how to achieve those goals. Even if the whole world were to adopt in a binding contract Great Britain's goals, it would not be enough to prevent more than 2 degrees of warming. So if you think about that, does anyone get like the same physical stress response as when some tattooed guy sits down next to you on the bus? Probably not. And I think you'd objectively agree that it's probably more dangerous than this tattooed guy who's just like trying to go to work. The problem is that the tattooed fellow presents a potential immediate risk, whereas climate change is some future risk that's much more abstract in nature. And unfortunately, medical risk is very similar. So it usually is going to happen at some time in the future. We don't know exactly when, and it's almost always invisible. Our minds are just not designed to comprehend and appreciate risks of this nature, and so we need to give our patients the best chance they have of understanding them. So I'd like to get a sense of your current practice on how you convey risk. I'm going to give 2 scenarios and then a couple of options. So the first scenario is you have a patient with new onset AFib, and you've enrolled them in the RAF2 trial, of course, and then you're going to cardiovert them, and the patient asks how dangerous is the sedation for the cardioversion. And then the second situation is you're getting consent for a blood transfusion, and you're discussing the risks and benefits of the procedure with the patient. So in these kind of situations, Raise your hand if you just don't discuss risk with the patient. So no, okay? Raise your hand if you tend to use qualitative statements like, you're at very low risk of this complication, or you're at high risk of having this outcome. So this is the majority of people. What about using comparators, things like, you're more likely to have a car crash on your way to work than you are to have such a thing, or you're more likely to win the lottery. So we've got a couple of hands for that. And then finally, raise your hand if you tend to use numbers, things like you have a 2% risk of respiratory depression, or this medication will cut your risk in half. So again, a handful of hands. As an aside, I'd like you to raise your hand if you've ever told a patient they're more likely to win the lottery than to have some bad outcome. Oh, I think some of you are lying. I've heard a lot of people say that. So there's been actually a couple studies that look at how the communication strategy affects how the patient perceives their risk. So first, failing to discuss risk at all is extremely common, and it's often appropriate if there's one clearly medically preferred option. However, if there's several options and we're trying to have the patient choose between them, this is obviously not ideal. The most common way that doctors discuss risk is using qualitative terms, things like there's a low risk of this, or this complication is extremely rare. However, it's been repeatedly shown that when patients receive this kind of information and then are asked to quantify their own risk, they routinely overestimate their risk, often by more than a factor of 10. Using comparators can be useful, especially when it's kind of a medium risk situation, but they can sometimes be misleading, and in particular, people's perceptions of how likely these comparators actually are can be wrong. And finally, many patients and also many physicians find numbers confusing, but I would suggest that when done well, quantifying risk numerically is probably the best option. So if you picked up a sheet on your way in, you have a list of events on a sheet, otherwise they're up here. I'd like you to take about a minute to try and rank them in order from least likely to occur to most likely to occur. Okay, so keep your answer in mind. This is what the answer should actually look like. So your lifetime risk of being in a major MVC is about 1 in 3. About 1 in 100 people will die from an MVC. You have a lifetime risk of 1 in 3,000 of being hit by lightning. And then things start getting a lot less likely. So modern day risk of getting HIV from a transfusion is about 1 in a million. Being hit by lightning twice is about 1 in 9 million. And then your chances of any single ticket winning the lottery is about 1 in 20 million. The problem is even this diagram is a little bit misleading because I've used a logarithmic scale. And if you use a proportional scale, winning the lottery or being hit twice by lightning is so unlikely that it makes everything else, including being hit by lightning once, seem almost certain to happen. And it would also turn out that if you've ever told your patient they're more likely to win the lottery than anything, you were lying. You're more likely to become prime minister or be hit in the head by an asteroid than you are to win the lottery. So let's talk about expressing risks using numbers. Unfortunately, most people don't have adequate numeracy to understand most statistics. As an example, when university graduates were surveyed, 10% of them, only 10% of them were able to identify that 1 in 1,000, and 0.1% were the same thing. The rest thought that they were different. A Cochrane review found that a patient's level of understanding decreases as we move from left to right in terms of ways to present statistics, with number needed to treat being really very hard to understand for most patients. However, even absolute risk reduction and percentages can be confusing, especially if we're presenting more than one in the same conversation. Combining percentages can be particularly tricky. For instance, take the problem here. So we have a woman whose baseline risk of breast cancer is 1%. If she has a mammogram for screening for breast cancer, there's an 80% chance that it will be positive. But if she doesn't have breast cancer, there's still a 10% chance that the mammogram will be positive. And the question is, if she goes for screening with a mammogram and it's positive, what is the likelihood that she has breast cancer? I won't ask you to calculate the result, but I would like you to raise your hand if you know right away how you would calculate the result. So there's like 5 hands. One of them is a ClinEpi fellow. The other ClinEpi fellow did not raise his hand. That's alarming. And so then I won't ask, but clearly, or I would assume that none of you can do it in your heads at least. I'll tell you the answer is 7.5% of women who have a positive mammogram will go on to have breast cancer. And coincidentally, that's the same percentage as the percentage of physicians that can correctly get this answer given a paper and pencil and adequate time to solve it. It's certainly not something that we can expect our patients to do in their head on the fly during a conversation. So if we're going to use numbers to quantify risk, and we don't want to confuse our patients, then we should probably be using what are called natural frequencies. A natural frequency is just representing a percentage as a proportion. So an example would be, instead of saying 2% of people will have respiratory depression, you would say, out of 100 patients having this procedure, 2 will have respiratory depression. I've been reading about this for quite a while, and it still strikes me as like a very subtle and almost no change at all. However, there's lots of evidence from within medicine and other fields as well that using natural frequencies leads to much better understanding among the general population. And when data is presented to patients in this way, the patients feel much more confident with their medical decision-making. So there must be some difference. Another benefit of natural frequencies is that you can easily change the denominator or the base. So for instance, you could say something like, out of 10 patients who have a kidney stone like yours, 7 will pass their kidney stone on their own in 1 month. If we reword the problem from earlier, it would look, using natural frequencies, it would look something like this. So out of every 1,000 women, 10 will have breast cancer. And out of those 10 women with breast cancer, 8 would have a positive mammogram on screening. Out of the other 990 patients who don't have breast cancer, about 100 would still have a falsely positive mammogram. So for every 1,000 mammograms, roughly 100 will be positive, and out of those 100, 8 women will actually have breast cancer. I think you'll agree that this is much easier to understand than it was with percentages. It may still be a bit tricky for some of our patients, but it certainly gives them a better shot at following what we're saying than the previous version. Any questions about natural frequencies? No. Okay. I don't have questions for you this time. Now, if we really want to give our patients the best possible chance of understanding medical risk, we can enlist the help of pictograms. I don't exactly mean pictograms like this. So consider I was saying that natural frequencies are proportions. And while easier to understand, proportions are still a kind of an abstract idea. However, physical or visual proportions are something that are inherently understood by people even from very early ages. So you can use a pictogram to represent your natural frequency as a visual proportion. And in truth, several studies have demonstrated that this is probably the best way to convey risk to our patients. So I'll give a couple of examples. Let's say you have an older patient with some dehydration and increased urea, and comes in with pneumonia. The patient kind of wants to go home, and the family are on the fence about it, and you're trying to kind of discuss what the risks of this pneumonia are for the patient. So you could use your CURB 65 decision rule, which would tell you this patient has about a 7% mortality in the next month. And then you could represent that risk this way. So this is a little pictogram with 100 people, and you've colored in the 7 who would die from pneumonia the next month, and you would present it as saying, out of 100 patients like you with this kind of pneumonia, 7 will die in the next month. For that reason, I think you should come into hospital, something like that. So they have a verbal representation of the risk as well as a visual representation of the same risk. One of the benefits of this approach is that it can be used, the same approach can be used to show the risks, but also the benefits of a medication. Where I clinically use this the most is when I have a patient with new AFib and I'm discussing with them starting an anticoagulant. So I have this template stored on a Dropbox file. So I would print off 2 copies of the template, and then I would look up the patient's stroke risk with the CHADS-2 score and their bleeding risk with the HAS-BLED scoring system. And then I would go sit with the patient with my templates, and the conversation would be something like this. So the main complication of atrial fibrillation for most patients is that it puts you at an increased risk of stroke. In fact, out of 100 patients who are like you with atrial fibrillation, about 6 will have a stroke within 1 year. Now, we have some medications that can reduce your risk of having a stroke. So this is now I've moved to the second template. And these medications are commonly called blood thinners. For every 100 patients like you who start on a blood thinner, only 2 will have a stroke in that year instead of 6. The main side effect of these medications is that it puts you at an increased risk of bleeding. Most of these bleeding events are pretty minor, but occasionally they can be more severe and you have to come to hospital for them. And about 1 out of every 100 patients on these blood thinners will have a bleeding event that's dangerous each year. So overall, for patients like you with atrial fibrillation who start on these medications, we save about 3 out of 100 people from having a bad outcome in 1 year. One response I've gotten when using this approach is, what about all those other people in gray? And so there's kind of 2 answers. First is I'm talking about a 1-year risk. If you were to say a 20-year risk, then the medication would prevent more strokes, but would also cause more bleeds. And then the other thing, though, is that this kind of highlights that these medications will have minimal effect for the daily lives of most of our patients. So in particular, if the patient is unable to pay for their medications and it's not covered, and maybe there's a less expensive but somewhat less effective medication, since the effect size is not huge to begin with, it kind of argues and helps the patient understand that, this cheaper medication is also a good choice. So some caveats. There's a couple of problems we run into when trying to use natural frequencies or pictograms. The first is that for events that are extremely unlikely, our brains are just not well equipped to understand how unlikely they are. In fact, once you get to a risk of about 1 in 10,000 or less, there's really, it's kind of meaningless to an individual person. Fortunately, most things in medicine that we're going to discuss in the emergency department have a risk kind of from 1 in 10 to 1 in 1,000. The major exception would be when you're discussing blood transfusion and a patient asks about HIV risk, mostly because of historic concerns. My approach when I'm asked this question is one of 2 things. If there's any kind of language barrier, I'm tired, the patient's tired, or I just think I don't want to give them too much information, I just say the risk is essentially 0, and it was only a historical concern, but now the risk is much lower than it used to be. If I'm feeling a bit more energetic, or the patient seems to want a little bit of a story or a chat or something like that, I'll give them the following analogy. So imagine you're standing in the middle of a football field, blindfolded, holding a pin, and there's a single ant crawling on the field. If you randomly walk around and put your pin on the turf, your chances of piercing that ant are higher than your chances of getting HIV from blood transfusion. Most people have that response and are no longer concerned. The other issue you can run into using natural frequencies is when you're just uncertain about what the risk is. And this happens more in emergency medicine than it does, I think, in other fields in medicine. And there's really no literature or evidence to guide us on how to convey this uncertainty to patients. I think if you have a ballpark idea, like you think the risk is somewhere in the 1 in 100 range, you could just kind of give a guess. But if you really have no idea, you're kind of out of luck. And probably you're best to just say that you don't know or try and use some kind of qualitative descriptor in that setting. So to sum up, if we go back to our discharge instructions, I would try and streamline the content of your message as much as possible, and where possible, use kind of a rehearsed message that you've planned in advance. I would also use the written discharge instructions as much as possible. And I've bolded it because I think this is the one that is easiest and makes the biggest impact. I would suggest that you verify patient understanding by having them repeat the instructions back to you. And when discussing risks or benefits with patients, I would suggest that we should be using natural frequencies to help convey those risks, and that for certain planned discussions, you could consider preparing pictograms to help display those natural frequencies visually and improve our patient understanding. I'd like to thank Dr. G, my supervisor, for helping me out with the slides, Dr. Hassan Sheikh for giving me his data from his resident research project, my wife Nora for listening to me to talk about this for several weeks now, and also Nick Costain for lending me his laptop and coming in early. Are there any final questions, concerns, criticisms people would like to make?
Just a couple of comments. One of the things that I didn't hear mentioned that's sometimes useful, especially in the example you used about a chest pain, is to ask the patient what they're afraid of, what are they concerned about, what's on their mind, so that in your discharge summary, you're perhaps addressing that concern. And the other thing about pictograms, it's a common thing that when we have a digital image where we have colors defining different aspects of it, you then print out in black and white, a lot of your impact is lost, and you have to kind of consider that in the design of your pictogram.
So there was two comments. The first one was about soliciting the patient's concerns and then specifically addressing those concerns in our discharge instructions. And the second one was about if you make a digital image of a pictogram and then print it out, you can't really see very well the colors in black and white. So I would agree, when I use this clinically, I print it out all gray, and I go in with it blank, and I will, at the bedside, I'll say, so 6 people will have a stroke, and I put X's on those 6 people. It's a bit morbid, but that's what I do. And then for the second example, when I'm trying to highlight, like, these 3 people are improved by the medication, I'll circle the 3 that got better with the medication, and then the other 3 still have X's. Yeah, if you try and print it out, it just all looks gray. It's not very helpful. Dr. Quinn?
There's a survey of our quality that sent out to patients in order. And they ask what happened with doctors, nurses and doctors work together. We do very well on that. One question they ask is, did the doctor explain to you the danger signs that would require you to come back to the emergency room? And we score very poorly. And so do all the other emergency departments in Ontario. I've always thought that was interesting. You tell people, well, if you have this chest pain or you get paralyzed in your arm, you should call 911. And we all say it, right? But they're answering that we don't know. So I think that's a key thing. So I think it would help us to emphasize, say, one of the danger signs that would be dangerous for your health is if your arm gets paralyzed, you should call 911. That's so they're not getting the point of how important some of these key messages relative to the other information we're giving. And that's sort of been our experience in asking patients to deal with these messages. So I thought I'd bring that up.
So the point was patients fill out surveys occasionally after their visits, and one of the questions is, did the doctor discuss reasons to return or dangerous signs that you should come back to the emergency department for? And the patients routinely say that it was not discussed. And actually this is mirrored in several of the studies looking at patient understanding. The domain that patients do most poorly on is reasons to return back to the emergency department. And so the suggestion was that if we label it as like, these are dangerous signs and I want you to come back to the emergency department, that kind of triggers in the patient's mind that really they should be paying attention. And I think also having them repeat it back to you, again, triggers in the mind that you think it's important, and that's why you're checking.
I'm just relating to Dr. Quinn's comment. Do you think, I think we're all very aware, as Dr. Quinn said, that we always say reasons to come back. And I wonder if we're trying to protect ourselves medical legally, so we're just giving them 10 reasons to come back to the emerge, and we fill in that little bit of jail-free box on the ROT, like short breath, chest pain. I wonder if they're just overloaded. Come back, you have chest pain, shortness of breath, fever, unwell, concerned.
then it's just like, okay, well, what if I was here in person?
Yeah, so the comment is sometimes maybe we give so many reasons to come back that the patient is kind of like overwhelmed with all the reasons. I think that's a valid concern. There's no like literature to guide us. One suggestion that I have had from some of the more senior staff would be if there's like one thing that you're really worried about, list that, and then you can routinely say something like, if you're feeling like things are getting worse, come back. Because that does cover like a majority of like COPD or cellulitis, like a majority of situations. The patient came in because they were bad. They should probably be aware that they're getting worse again. They should notice. Rajiv?
Do you guys have a way of building in like a little buffer for just doing judgment as well? It's like I always feel a little bit guilty saying like, oh, if you get X, Y, Z. But I kind of just feel almost like this person is probably like, so I have like persist or whatever. Like, is there a safe way to say like within reason?
So I think the question is, do you have to list like all the danger signs, or if they seem like the patient would automatically understand that they should come back for that, can you just leave it up to them? Is that kind of the question? No. I see what you're saying. So some diseases, yeah, so I think there is a role for that. Like take cellulitis. You expect cellulitis not to be better tomorrow, not to be better on Thursday. It's going to be better next week, maybe. So I think that's part of your discharge instructions is telling the patient, I want you to take these antibiotics. It's going to take 4 or 5 days before you start to feel better. That's normal. Please come back if whatever. But if it's the same, you're fine at home. Does that answer your question? Yeah, okay. Sean?
So Alicia has this great East Coast way of talking to people before they leave. She says, you're only allowed to get better. Okay? She says, it's okay if you don't get better for a few days, but you're only allowed to get better. And if you're worse at any point, I want you to come back. And then she'll give them a bullet of like 2 or 3 things at the end that are particular concerns. And I always thought that the patients kind of felt warm and fuzzy by that. It was a nice way to do it.
Yeah, I like that. Dr. Wu?
Another key point is, and I think Janet, I'm not sure if she's here, has told me as well, is persistence of symptoms, particularly other, NYD cases is another reason to potentially come back, or no family doctor or...
Your conference is scheduled to end in 2 minutes.
Not able to access the primary physician in a timely fashion, so that's another key point sometimes that I will also mention. If you have persistence of symptoms, depending on what they are, for a week or 2 weeks, come back.
So the comment was just if you can also mention that if symptoms are persisting longer than you expect them to, or especially if you're not certain about what the diagnosis was in the first place, that's another reason for patients to come back, even if they're not getting worse, if it's just not improving for a long period of time. I think with that we'll wrap up because there's M&M after this. If you picked up a sheet on your way in, this is on the back of it. If you feel like it, you can fill this out and leave it at the table, and I will be grateful to you. Thank you. Thank you.